On behalf of Zydus, I welcome everyone today. For further proceedings, I'd like to hand over session to Dr. Amit Pran, sir. Over to you, sir.
Thank you, Dr. Suyash. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Abhishek Sharma from Kolkata, and he's going to lecture us on interpretation of peripheral blood smears. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Abhishek Sharma from Kolkata. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending the Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 6th of October 2024 from 11:30 a.m. Indian Standard Time, your Dr. Devdutt Basu from Pondicherry speaking to us on when your cells go missing, unraveling the mystery of pancytopenia. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhishek Purohit from AIIMS Jodhpur, Dr. Akshay Manloy from Agilus Diagnostics Mumbai Reference Lab Mumbai, Dr. Amrit Kaur Keller from Kokilaben Dhirubhai Ambani Hospital Mumbai, Dr. Amrita Saraf from Sir Gangaram Hospital Delhi, Dr. Anju Bharti from Banaras Hindu University Varanasi, Dr. Ankur Ahuja from AFMC Pune, Dr. Chamindi Jayasundra from National Cancer Institute Sri Lanka, Dr. Chitra Madivale from PD Hinduja Hospital and Medical Research Center Mumbai, Dr. Deepak MB from MSMC Narang Health City Bengaluru, Dr. Durga Devi S from Manipal Hospital Bengaluru, Dr. Neemya Thanda from North Okalarpa General Hospital Myanmar, Dr. Hormas Diyar Soli Sadri from Navsari, Dr. Jyoti Soni from Gujarat Cancer and Research Institute Ahmedabad, Dr. K. Gayatri from Lifeline Tapadia Diagnostic Center Hyderabad, Dr. Kunal Goyal from Kokilaben Dhirubhai Ambani Hospital Navi Mumbai, Dr. Meenakshi Suri from Jammu, Dr. Meenu Angi from Unipath Specialty Laboratory Ahmedabad, Dr. Mohammad Taha Ali Khan from Medicover Hospital Hyderabad, Dr. Myat Malleshwe from Menle, Myanmar, Dr. Nipunika Senadhira from Colombo, Dr. Omshi Shetty from Tata Memorial Hospital, Parel, Mumbai, Dr. Parimal Sarda from Hematology Oncology Clinic, Vedanta, Ahmedabad, Dr. Pratik Bhatia from PGI Chandigarh, Lieutenant Colonel Dr. Rama Hariharan from Command Hospital, Lucknow, Dr. Ramesh Balasubramanian from Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu, Dr. Ritesh Kharche from Seven Hills Hospital, Mumbai, Dr. Rupam Deka from AIIMS Guwahati, Colonel Dr. S. Venkatesan from Armed Force Medical College, Pune, Dr. Sandeep Sheth from Zydus Hospital, Ahmedabad, Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida, Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Abhishek Sharma from Kolkata. Dr. Abhishek Sharma is Assistant Professor at the NRS Medical College and Hospital, Kolkata. He is head in charge and lead Hematology Department, Services of Super Specialty Department of Hematology, the Hematopathology Division. He did his MBBS from RG Kar Medical College, Kolkata, MD Pathology from Bardwan Medical College and DM Hematopathology from prestigious PGI Chandigarh. He has been associated with teaching under WBMES for the last 15 years. He is vastly experienced in hematology, serving high-end tests like flow cytometry, molecular hematology, fish specialized coagulation, and hemolytic services, including bone marrow aspiration and refined biopsy. He has several national and international publications. He is the first author for chapters of the landmark book, the PGI Textbook of Hematology. He is a reviewer of PubMed Index journals and is in the advisory committee of Thalassemia and Hemophilia SOP for West Bengal government. He has experience in teaching UG, PG, and DM students. He is also a member of IAPM and ISHBT and an active participant, faculty member of various CME, workshop, and hematology conference. His main area of interest is flow cytometry for BALL. And today he's going to lecture us on interpretation of peripheral blood smears. Well, thank you so much. Over to you, sir.
Thank you, sir, for the kind introduction. I'll just share my screen. I hope my screen is visible.
Very visible.
Yeah, and I'm audible as well.
Yes, that's good.
Thank you. So, at the onset, I'd like to thank the entire Mumbai hematology group, especially MB Agarwal sir and his entire team, for giving me this opportunity to talk on this very basic but extremely important topic of peripheral blood smear interpretation. And in this period of 45 minutes or so, I like to take you to the journey of various informations and the puzzle a simple glass slide can solve. And I presume, and I think that most of the audience listening to me will also agree that there is some sort of gap between the information that we extract from this simple glass slide smear and the information given to our clinician. And again, I strongly believe that this peripheral blood smear can act as a strong bridge in closing this gap between the laboratory side and the clinical side. So the flow of my talk will be, I'll introduce the topic, we'll discuss about the utility and the indications of the peripheral blood smear. We will see how to go about the general principle of interpreting it, and we'll see the different components, how to assess it. We will also see some non-hematological findings like hemoparasites and artifacts. And if time permits, I'd like to talk something about troubleshooting, and I finally end with take-home message. So let us start with this simple cartoon of a peripheral blood smear, which we all as a hematopathologist or hematologist have been seeing. So this simple glass slide provides us a lot of information. When I see lot, it can be a load to someone or a burden to an individual if you are not methodical in extracting the information. And it is only by a good morphology that you can convert or extract this lot of information into clinically actionable products. That is by simple interpretation. So here lies the importance of a fruitful, timely, correct interpretation where we can extract meaningful information from this loads of data that is present in our simple glass slide. So coming to the utility of peripheral blood smear, we are all aware that it helps to diagnose and monitor the disease. Not only that, it can also help to detect the pre-analytical and the analytical errors that can come as a part of an automated analyzer. It helps to correlate the instrumental flags, and it can also bring surprises in the form of additional information, which I'll talk during the course of my presentation. So before I move forward, I like to quote one of my teachers who used to say that peripheral blood smear is the window to bone marrow, and it provides a lot of useful information which opens the window to the world of clinical diagnosis. So the indications, the first and the foremost indication is the clinical request, which is often based on the clinical clues or maybe as a result of a past abnormal result. Apart from that, the indication of peripheral smear can be generated in a lab as a part of laboratory request, which can be due to the lab policies or due to correlation of the instrumental flags. Apart from these two, which is the common indications, peripheral blood smear can also be made as a result of just curiosity, exploration, or maybe an academic workup. Going ahead to how to go about the process of examining a peripheral blood smear in a methodical and a concrete way. But before I move forward, there is a strong note of caution to all of us that please do correlate peripheral blood smear findings in the background of an appropriate clinical history with your histogram and with the automated CBC parameters. So coming to first things first and the foremost thing that we need to see before even we attempt to extract information from a peripheral blood smear is the quality of smear and stain. We have all seen an histopathology report. The first part of an histopathology report is the gross examination. So before even we attempt to see a peripheral blood smear, it's always better to macroscopically or grossly look at the quality of the smear. And that can give a lot of information. I'll cite some examples. These are the 4 different smears, and each smear speaks out something. In the second row is a normal looking smear. The third row, which is a bit thinner or the pale looking smear, indicate that the patient might be anemic, while the smear on the extreme left having a more thick or a reddish appearance, indicating that this might have an increased RBD density due to polycythemic nature of the patient, and the bluish nature of the smear can indicate presence of some protein, which can indicate that the patient might be suffering from some sort of gammopathy. Coming to the second thing, once we have a good quality of smear and stain, we need to choose correct area for reading out our slides. So choosing optimal area for the correct assessment, and not only that, correct technique is utmost importance for the fruitful extraction of informations. And the different parts of an smear, as we are all aware, is the body, tail, and the best area to examine a peripheral blood smear is the part which is neither too thick nor too thin, which is usually located half inch just below the edge and the margins. And this area is important because here the RBCs are uniformly distributed and we can get a good morphology. And once we have a good area, we have to examine each and every part of that optimal assessment area. We can move from right to left or left to right so that we don't miss out on any important clues or abnormal cells that might be present. Why this optimal area? Because if we are studying a thicker area, we tend to see more of the spherocytes, which are pseudospherocytes. And if we look at the edge of the smear, that is the thin smear, we look to see more of the spherocytes. And if we move at the thick smear, we tend to see more of the rouleau formation. Having said that, we must follow this optimal method or technique when we have a true or a normal count. But one must be aware, if we are looking of a pancytopenia or extremely leukopenic sample, we might not be able to find the area of interest when we are looking to this area. So we should examine all corners of the slide, because in that case of leukopenic patients, you are likely to find that the suspect in the tail and the edges of the smear. The classical example is an acute promyelocytic leukemia, which classically presents with pancytopenia. And if we examine the tail ends, we might pick up some abnormal promyelocytes, which can help in diagnosis. Coming to the low power field, we look for the distribution of the cell, specifically the platelet distribution. We can pick up the platelet clumps, and we can also get hold of some fibrin strands, which can occur as a part of pre-analytical error. Moving to high power field, at high power field, we tend to look at the morphology of the RBC. We get an estimate of the total count of the WBC and also the distribution of the WBC, for which we have to study at least 10 high power field, and we can get a rough estimate of the true WBC count. Moving on the next higher field, that is the oil, where we look for the concrete morphology in terms of the RBC, WBC, and the platelets. We can also study about the RBC inclusions, hemoparasites, and other abnormal cells. Having this background set with the good quality of smear and good staining, having good technique, let us see what to assess in the case of RBC morphology. So as far as RBCs are concerned, a peripheral blood smear can give us an idea about the variations in the shape and the size of the RBC, which is documented in the form of anisocytosis or poikilocytosis. It can also give an idea about the chromia of the RBCs, polychromatophils, rouleau formation, agglutination, and inclusions can also be very well picked. This is an extremely important and a very nice study paper, which has all the recommendation and the guideline as to how to use this nomenclature, and not only nomenclature, how to grade the peripheral blood abnormalities as far as RBCs are concerned. We tend to report RBCs in the form of anisocytosis, spherocytes, elliptocytes, but we never grade them. But this paper, very important for any undergraduate or postgraduate students, which has all the intricate details that how to report an elliptocytes, how to grade them, what is their clinical significance, what is the cutoff at which we should report it or we should ignore it. So I'll just give one example. This is the table from the same study. It's a busy slide. I'll not go into the entire points. Just one example. If you look at the elliptocytes, if it is less than 5 elliptocytes per high power FIT, we tend to ignore it. Anything more than 5, we need to report it. And depending on the number of elliptocytes, we need to grade it whether we are dealing with a mild elliptocytosis, moderate, or a severe or a marked elliptocytosis. Moreover, in terms of teardrop cells, the cutoff is 4%. Anything less than 4% is usually ignored. But if in the background of a appropriate clinical history and presence of a numerous RBCs, the teardrop cell should also be reported if it is less than 4%. Coming to the size and the chromia, we very well know that MCV gives us an idea about the RBC size, but this is a derived or a calculated parameter. We have our morphology to reconfirm it. And how do we do it? We compare the size of the RBC with the size of the nucleus of a small mature lymphocyte. Any RBC close to the size of a nucleus of the small mature lymphocyte is a normocytic. Anything lesser than that is called a microcytic RBC, and the bigger than that is called a macrocytic RBC. The commonest differential of a microcytic hypochromic anemia is an iron deficiency anemia and calculate, where we can see the RBC morphology in clinching the diagnosis. In case of iron deficiency anemia, we do have an additional clue in the presence of pencil cells, which are very diagnostic hallmark of an iron deficiency anemia. Microcytosis, as I said, we need to document it, and not only document it, we need to grade it depending on the degree of the microcytes present in the smear. Similarly, for hypochromia, if it is present, we need to note it, and similarly, we need to grade whether it is a mild form, moderate form, or a severe form of hypochromia. Let us take two clinical scenario in which there are two middle-aged women, one suffering from menorrhagia, one is primigravida, having mild pallor, microcytic hypochromic blood picture on red cell indices in case number 1. In case 2, it is microcytic hypochromic, which is of more severity than the previous case. The RDW is on the higher side, that is 19%. The normal is more or less 14.5%. In the case 2, the RDW is near normal. The RBC count in the first one is 4.1 million, while in the second one, it is on the higher side. So what are we dealing with? I'm sure most of you have got it right. So probably we are dealing with iron deficiency anemia in case 1 and thalassemia trait in case 2. And we have a lot of other indices in the forms of mentor indices, which can also give us some idea about the clinical entity that we are dealing with. Hal major, yes, they are diagnostic clue. There are a lot of NRBCs that can be encountered, and we usually see marked anisopoikilocytosis in the form of teardrop cell, microcytes, as well as a lot of target cells in the patients of Hal major. Basophilic stippling, another important finding that can be picked up on a peripheral blood smear, and there are a lot of clinical entity in which basophilic stippling can be seen. The common one is sideroblastic anemia, lead poisoning, relatively less commoner in our place, but it can be seen. Dimorphic anemia, yes, as the name itself says, that we have two morphological forms of RBC. Depending on the type, it can be microcytic, macrocytic, or normocytic, or combination of any two types. And there are a lot of causes of dimorphic anemia, which can be response to therapy or a transfused patient in a case of a microcytic hypochromic anemia. And if you look at the histogram, this dimorphic anemia will always give a dual notch or a biphasic pattern, which can be again picked up in the basis of an appropriate clinical background. This is another picture of a dimorphic anemia where we can see that most of the RBCs are predominantly smaller in size, that is microcytic hypochromic, but in the background we can see some dark colored, fully oranges type of RBC that are spherocytes. Probably this patient was transfused, and these are the transfused RBC, again indicating that transfused RBC in a patient of microcytic hypochromic anemia can give rise to a dimorphic anemia like picture. Coming to the larger ones, pancytopenia, macrovalocytes, presence of hypersegmented polymorphs and cabot rings point us towards something that we are dealing with a nutritional anemia, that is megaloblastic anemia, and the common cause of this is the folate and the vitamin B12 deficiency. But one must also take care keep in mind that they are non-megaloblastic causes of macrocytic anemia, of which the commonest is the hypothyroidism, liver disorders, and other causes. Normocytic normochromic anemia, yes, as the name says, there is anemia, but as far as the morphology or the MCV is indicated, they are within normal range. So the size of the RBC is absolutely normal. So this was a case of a 10-year-old child presenting with severe anemia with a hemoglobin of 5.5. On the morphology, it turned out to be a normocytic normochromic anemia. So what are we dealing with? If we closely look, if we are all aware that the reticulocyte count in a normal individual varies from zero point 0.5 to 1.5. So if we look at around about 10 to 15 high power fields or an oil immersion field, we should get some sort of polychromatophils. But in this case, we didn't got any polychromatophils. So the point I want to highlight is not only the presence of an abnormality, even the absence of a thing can give a clue to the diagnosis. So in this case, the patient having severe anemia, it is supposed that the body should respond and the reticulocyte should have come up. But in this case, we couldn't find any reticulocyte count. So the bone marrow was examined, which was quite cellular. And in the background, we can see this large type of cells, this large type of bluish cells, which on high power will have some protrusions, giving us a dog ear-like appearance with some inclusions in the nucleus, giving or clinching the diagnosis of a parvovirus infection. So peripheral blood smear, absence of anything can also give us clue to what are we dealing with. Is there a clue to a hemolytic process on a peripheral blood smear? In fact, yes, presence of polychromatophils, presence of NRBCs can definitely has an indication that we are dealing with a hemolytic anemia. And moreover, there are certain specific morphological abnormalities that can pick up some specific type of hemolytic anemia. I'll come to this in my next slide. Can we diagnose a spherocytic anemia? Yes, presence of spherocytes, numerous spherocytes and uniform shaped spherocytes throughout the smear can give an indication of spherocytic anemia, and we have a family history. We then we have to confirm it with some other tests like osmotic fragility test, which can be done by a conventional method, and nowadays it can be moved to a flow cytometer. EMA test has taken over these days in most of the diagnostic lab for the specific diagnosis of hereditary spherocytosis, which is done with the help of a flow cytometer. I'll just deal with a case. It was an 8-year-old male presented with unconjugated hyperbilirubinemia, and there were presence of numerous spherocytes on peripheral blood smear, and there was increased osmotic fragility test. So this patient was taken up for an EMA test. So the basic principle of an EMA test is we run the patient sample and we run the controls, and we look at the mean fluorescent intensity of the EMA dye, both in the patients and the control. Usually we have to take 5 controls, and in this case, we can see that the MFI of the control patient was on the higher side, while that of the patient was decreased because there was some genetic defect of spherocytosis, and the ratio of the patient and the control is calculated, and you have to have your own cutoff standardized in your lab. In our lab, we have a cutoff of 0.8. So anything which is less than 0.8, and in this case it is 0.74, clinches the diagnosis of hereditary spherocytosis. Again, as I said, osmotic fragility test can also be done with the help of a flow cytometer. This is a diagram showing an osmotic fragility test done on a flow cytometer, and this can be done in any center which has a flow cytometer. We don't need any high costly antibodies for this. All we need is a distilled water. We can see the healthy patient and our suspected patient, where after adding distilled water, the residual red blood cells in case of healthy control is around close to 50%, while in case of suspected patient, it is less than 10%, showing that the patient RBCs are more fragile, thus clinching the diagnosis of hereditary spherocytosis. So spherocytes in peripheral smear doesn't always mean hereditary spherocytosis. There are numerous other causes, and there are clues for each of these causes on a peripheral blood smear. As I already said, for hereditary spherocytosis, there are spherocytes, but these are uniform size and uniformly distributed throughout the smear. For autoimmune hemolytic anemia, again we will get spherocytes, but they will be variable in size, and we will have NRBCs, and agglutinations can also be seen. Hemolytic disease of newborn, There can be spherocytes, but there will be many NRBCs as well. Transfused RBC, I just saw an example. There will be some transfused RBC showing spherocytes in the background of the patient's RBC. Microangiopathic hemolytic anemia, yes, and burn can also be picked up provided we will have some sort of RBC fragments or cystiocytes indicate that we are dealing with this entity. Is there a clue for membranopathies? Yes, we can pick up elliptocytes or somatocytes. And again, I refer to that paper, which will guide us what to report, and how to grade this RBC's abnormality. G6PD deficiency, again, the classical hallmark cell that we get in a peripheral blood smear is a blister cell or a bite cell, because these are the cells which are engulfed by presence of deficiency of G6PD, and the classical morphology of the cell is again diagnostic of itself. If we are still dealing with a hemolytic cause and we have ruled out all the common causes of hemolysis and still there is an unexplained cause of hemolysis, one should always suspect an underlying PNH. And for diagnosis of PNH, flow cytometry is the way to look forward. I'll just show one plot of flow cytometry. Here we acquire the continuous events. We get the doublets. To exclude the doublets, we exclude our cellular debris and we go on to the classical plot of site scatter 45, where we get all our viable cells. As the guideline says, for PNH, we have to study 2 lineage markers and 2 markers on each lineage. So for this, we study the neutrophils and the monocytes. For neutrophils, we use CD15 as the gating marker. So we have gated CD15 positive cells, which are the neutrophils, and we look for 2 markers, that is GPI anchor specific in the form of CD24 and FLAIR. And we can see that this red population is deficient in CD24 and FLAIR, thus indicating that this neutrophil is positive for PNH. Similarly, for monocytes, we use 64 as the gating marker and look for expression of CD14 and FLAIR, and we can also see that this is also showing roughly 1.5% of the population which is deficient in this GPI anchor protein, thus clinching the diagnosis of PNH. Not only the WBCs, we need to also look for the RBCs for the PNH, and here we get the RBCs and we look for CD59. We can use as a FLAIR also, and we need to subtype the different population in the form of type 2 PNH or type 3 PNH, which has got clinical significance. Pyrimidine 5' nucleotide deficiency, yes, there is some diagnostic clue. We can get basophilic stippling, which are coarse in nature, but this stippling can be found in other conditions, and we need some sophisticated tests or maybe molecular genetic tests for confirmation. As I said, basophilic stippling can be found in a lot of conditions, and these are nothing but abnormal aggregated ribosomes. But again, a note of caution to the young hematologist or hematopathologist, that whenever you are trying to look for an ribosomes, aggregated ribosomes in the form of basophilic stippling, one should be very meticulous that your smears are prepared as soon as it arrives, in less than 1 or 2 hours, because with prolonged storage of blood in EDTA, this basophilic stippling is lost and you might miss some clues for your diagnosis. Well, all engynopathies doesn't have characteristic morphology. Pyruvate kinase deficiency, which is itself a very rare, but it doesn't have any morphological clue as far as I know. So even if there is a clinical suspicion of an enzymopathy, and if you are not getting any sufficient clue on peripheral blood smear or other common tests, one must look forward for ancillary tests like molecular genetic tests or sequencing to pick some of the cases which are rare itself. Hemoglobinopathies, again, yes, peripheral blood smear has certain clues. We can get some sickle cells or boat-shaped cells, some elongated rod-like inclusions which can be seen in HBC disease. Target cells, again, a very common finding which is not that very specific of a disease entity, but it can be seen in the background of a microcyte, normocyte of a macrocyte, and it can be seen in a lot of hematological diseases, including thalassemia, sickle cell, or liver disease. Agglutination, yes, it can be picked up in the form of a 3-dimensional grape-like structure, and there are other clues in the form of histogram. If you look at the histogram or the RBC indices, if the patient is suffering from a cold agglutinin disease, we tend to get less number of RBC count, and the MCV is extremely high, to the range of 130 and 140. So what we need to do is we need to warm this sample at 37 degrees Celsius, again run our samples, all the RBC parameters will come to a normal range, and thus we can get an idea that probably we are dealing with a cold agglutinin disease. And there are other clues like in the forms of presence of spherocytes, NRBCs. There is something called rosetting. There are presence of rosettes of RBCs around the neutrophil, which again might point that we are dealing with a cold agglutinin disease. Rouleau formation, presence of stacked coin-like structure in a proper area, provided we are not looking at a more thicker area, can give some idea that we are dealing with a true rouleau formation, which can be due to presence of protein in the smear or presence of a plasmacytoid cell or a plasma circulating plasma cell that can be picked up, giving us that probably we might be dealing with a case of a plasma cell dysplasia. Histiocytes, again, this is one of the two of the most common hematological emergency that one needs to pick up. Fragmented cells, they can come in various morphological forms in the form of a triangular cell, horn cell, helmet cells, or microspherocytes. And there is a entity called microangiopathic hemolytic anemia, which has lot of distinct entities again. But the important point here is to identify the histiocytes, and there are various forms of histiocytes, and this is another very important, very nice, very beautifully written update of ISHT, which guides us which cells to call histiocytes, what is the diagnostic value, what is the clinical impact, and how to document the histiocytes in an appropriate clinical background. Spur cells or acanthocytes, yes, these are longer and lesser these are longer and lesser number of spikes on the surface of the RBCs, which can be seen in large number of conditions and is very specific of a liver disease, especially alcoholic liver disease. The close differential diagnosis that comes to of a spur cell is an echinocytes or a burr cell. The difference between the acanthocytes are here the spikes are shorter and they are more numerous in number, and it is commonly seen in renal patients or uremic patients. Teardrop cells, another important finding, and I said that anything more than 4% is abnormal, has to be documented, and the presence of teardrop cells on a peripheral blood smear can also indicate that probably we are dealing with a fibrosis in the marrow, and it's quite commonly seen in case of primary myelofibrosis. RBC inclusions, yes, a good Romanowski stain will be able to pick up RBC inclusions in the form of basophilic stippling, Howell-Zawell bodies, or Pappenheimer bodies. So Howell-Zawell bodies are definite inclusions that can be picked up, but it can be easily confused with a platelet overlying the surface of the RBC. So the important clue to differentiate between a true Howell-Zawell body and a platelet overlapping on the surface of the RBC is if you see in this diagram, the RBC, if the platelet is superimposed on the surface of the RBC, they tend to displace the hemoglobin. So you will get a white halo due to the presence or overlapping or sticking of an RBC. While in case of a true inclusion, there will be no such halo. So one should not confuse with a platelet and a true Howell-Zawell body. Pappenheimer bodies present in the siderocytes can be characteristic of a patient dealing with a sideroblastic anemia. And again, to re-emphasize the fact that how to go about the reporting and grading of an abnormal red cell morphology, one should go through this beautifully written review. Moving ahead with the WBC morphology, the first and the foremost thing on a peripheral blood smear that we need to see in terms of a WBC is the total count. We need to see whether the WBC count is spuriously elevated because the NRBCs can interfere with it. And if we are getting numerous NRBCs, if they are more than 10, we need to do a correction with a time-bound formula. And moreover, apart from that, we need to look at the distribution of the RBC. We need to look at any penias or the philias. We need to look at the morphological abnormalities of a normal cell in the form of hypolobations and the cytoplasmic granulations, or even an abnormal cells can be picked up. Coming to the morphologies of neutrophils, the nucleus of a normal neutrophil is 4 to 5 lobe, but it can be hypolobated, which can be picked up and is a very classical of an myelodysplastic syndrome. We can get an hypersegmented neutrophil, which is again a feature of dysplasia according to the WHO, which is very characteristic of myelodysplastic syndrome. But in our country, India, nutritional deficiency in forms of B12 and folate is more common. So hypersegmented neutrophil usually we at our center do not consider it as a feature of dysplasia as far as MDS is concerned. Cytoplasm, again, it can give us a lot of clues looking at the granules. There can be hypogranulation, there can be hypergranulation, there can be presence of toxic granules, vacuolations. All of this indicates towards some sort of dysplasia or underlying sepsis. Bacterial infections can also be very well picked, and there can be presence of some crystals. These are often referred to as green or blue crystals of death in cases of severe sepsis in the cytoplasm of an neutrophil. Dole body is another important cytoplasmic inclusions that can be picked up in the neutrophil, which appears as a sky blue inclusion, and there are concrete disorders where they can be very characteristic. Pseudopelvic head abnormalities, hypogranular neutrophils with the bilobe neutrophils giving the characteristical spectacle shaped nucleus can also be one of the diagnostic clues. This is a case of an 8-year-old child with recurrent chest infection. We can see that there's spores inclusions, spores granules uniformly distributed over the cytoplasm of the neutrophil, indicating that there might be a case of a Chilaiditi syndrome. Vacuolations in the cytoplasm of a lymphocyte can also indicate that we might be dealing with a lipid storage disease. We need to confirm with other diagnostic modalities. Shift to left, presence of immature cells. We don't expect immature cells on a normal peripheral blood unless it is a premature infant. If it is there, we need to document it. And the presence of promyelocytes, myelocytes, and metamyelocytes are all reported together as a part of left shift. And band cells should be reported separately if we are dealing with a neonatal patient because that is an indication of a neonatal sepsis. Lab score, again, an important uh, cytochemical stain which can help us to diagnose whether we are dealing with an MPN or a leukomyid reaction. In a leukomyid reaction, generally the lab score tends to be on the higher side, while in case of CML, it will be on the lower side. Coming to the lymphocyte morphology, in a normal peripheral blood smear, we can see various forms of lymphocytes in the form of small lymphocytes, large granular lymphocytes, and if a patient is having some sort of viral infection, we call it virocytes or the transformed RBCs or the transformed lymphocytes, where the cytoplasm of the lymphocyte is more grayish and some sort of vacuolations or convolutions can also be seen. This is another transformed lymphocytes of various morphology where we can see that the border or the cytoplasmic is having some balena skirt appearance. These are referred to as downy cells, which is again very characteristic of certain specific type of infection. As far as lymphoid cell morphology is concerned, lymphoma cell can be spilled over in the peripheral blood and that can be very well picked on a peripheral blood smear. We can get some sort of large cells, cleaved cells with immature chromatin or partially clumped soccer ball appearance of the chromatin, which is classically seen in chronic lymphocytic leukemia, or cleaved cell, which can be seen in mantle cell lymphoma or blastoid variant. Eosinophils, mere presence of eosinophil as well as presence of dysplastic eosinophils, which can be picked up in the form of hypersegmented eosinophils. But one should keep in mind that the hypersegmented neutrophils as well as hypersegmented eosinophils can also occur due to presence of a drug, and the commonest drug that can cause to this hypersegmentation is hydroxyurea. Blast abnormal cells can come up and be very well picked up in the peripheral blood sphere, and we need to closely look at the morphology and pick whether we are dealing with a lymphoblast or the myeloblast. If we look and if we can detect the OR rods, we are happy enough that we are definitely dealing with a myeloblast, but there are other morphological clues to pick up this blast. Picking up blast and subtyping it according to the FAB classification is the need of an hour for a good morphologist. One should be able to subcategorize whether we are dealing with a myelomonocytic or monoblastic leukemia, or for that case, a myeloblast or a lymphoblast. As far as acute promyelocytic leukemia is concerned, it is the need of the hour and it is an hematological emergency. We need to pick up this uh, abnormal flow myelocytes, which can be picked up with this characteristic large cells eccentrically nucleus opened up chromatins. And if you are lucky enough, you can get multiple OR rods, which are called fagot cells. Even in the absence of fagot cells, if you see classical cells having this angel wings like of structure or bilobe cells, these are very much characteristics of acute promyelocytic leukemia. And the close differential diagnosis that comes in this case is a myelomonocytic leukemia. The simple cytochemical stain, that is an MPO stain, needs to be done, which can differentiate these two abnormalities in case of APML, irrespective of whether we are dealing with an hypergranular or a hypogranular variant, we will get a strong MPO positivity, while in a case of a myelomonocytic, the MPO will be on the lighter or not that strong. If you are lucky enough, the blast will be staring at you, but it's not always the case. If you are dealing with an leukopenic or a pancytopenic cases, you will have to meticulously search for it. And there lies the importance that you need to see all corners of your slide, right from the tail to all the margins where you can pick up some abnormal cells. As in case of an acute promyelocytic leukemia, which usually presents with pancytopenia, in case of hypoplastic MDS, and other cases of myelofibrosis, where you need to be meticulous in reading your peripheral blood smear. Coming to platelet morphology, the peripheral blood smear gives us an estimate of the count to look whether we are dealing with an increased or a decreased platelet count, whether it is a true thrombocytopenia or whether it is a pseudothrombocytopenia. And we can pick up some morphological abnormalities as well. So there are various causes of spurious low counts of platelets, and the commonest one is the platelet satellitism, and that can be induced as a part of an EDTA-induced pseudothrombocytopenia, which can be picked up, and we need to correlate with our CBC automated parameters. Non-EDTA procedural thrombocytopenia can also occur, and pseudothrombocytopenia can also occur as a part of partial clotting of the sample, which can again be picked up while looking at your peripheral blood smear. Giant platelets, the causes are numerous and it can be picked up, and it is one of the important diagnostic tools as well as platelet disorders are concerned. And these are the morphological pictures. Giant platelet, thrombocytopenia, presence of some inclusions in the neutrophil can be very characteristic of some diagnostic entity as far as hematological disorders are concerned. On the contrary, we can get spurious high counts of the platelets, and that can be due to presence of some fungi, bacteria, or fragmented RBCs, which are the commonest causes of spurious high count that can be avoided just by looking at your peripheral blood smear. Apart from this abnormal blood-related cells, we can pick up hemoparasites in the form of malaria or Wucheria and other parasites. Plasmodium vivax, ring forms, as well as gametocytes can be very well picked, and we need to do both the thick and the thin smears to pick up this entity. But there are other diagnostic clues for hemoparasites in the presence of monocytosis, and sometimes we do get these hemozoin pigments in the monocytes or even in the neutrophils that can give us some diagnostic clue to meticulously search for this gametocytes or this tropocytes of Plasmodium. Wucheria bancrofti can again be picked up on a peripheral blood smear without any staining, just direct mount. We can be able to pick up microfilaria as well as. Coming to the last portion of my presentation, that is the artifact. These are the commonest findings that one should be aware of and avoid. And these are usually human being made in a laboratory, which should be avoided for a quality smear and for a fruitful reporting. For troubleshooting, we as a morphologist loves color, and there are distinct color for each of these cells, whether we are looking at the nucleus or whether looking at the cytoplasm. And when we look at some cells or some slides which are pale staining, that the reason might be the slide have been too much acidic stain, or there must have been some insufficient staining time, or the stain has just become old or faded. And how do we go for correction? We can increase the first and the foremost method is to check the pH. If there is an alteration in the pH, to correct the pH, or if we can even try it by increasing the staining time. If there is a dark or ugly staining slide, the probable reason is that the stain is too alkaline, or there is insufficient washing, or there is prolonged staining. The time of staining is increased. So again, we need to check our pH and do alternative troubleshooting for concrete staining. This is an slide showing some sort of hypochromia, but this is not a true hypochromia because apart from a true hypochromia, which is blurred, here we can see that the margins are very well demarcated and some blotchy appearance. So this is probably a case of a water artifact where some water has spilled over the staining slides, or the time of the year in the winter season or in the rainy season where the stain bottles are left open and the humidified air absorbs the water. So probably the stain contains more water that can lead to this artifact, which can be easily avoided. And one must be aware of this artifact and should not report this as hypochromia. I'll just end up with one interesting case, which I think I will present to show the importance again of morphology in picking up the diagnosis, and not only picking up the diagnosis to guiding how morphology can help in ancillary tests in clinching the final diagnosis. So this was a 3-year male patient presented with fever and bilateral knee pain for 3 weeks. There was a history of 4 units of blood transfusion. On examination, there was purpura and hepatomegaly for 4 centimeter. There was a family history of an elder sister which expired at the age of 8 years, and there was a clinical suspicion of acute lymphoblastic leukemia. This was the case which I encountered when I was a resident, and Jasmina ma'am, my teacher, was the reporting consultant that time. So this was the peripheral blood smear, which revealed that there is mild anemia, and we could pick up some abnormal blastoid cell, which amounted to 61%. So this was the morphology of the blast on the peripheral blood smear. The marrow was done, and we could see this abnormal cells throughout the smear, which amounted to 78%. Again, a blastoid morphology with abundant cytoplasmic vacuolation filling up the whole of the cytoplasm. So what are we dealing with in a child with hepatomegaly, clinical suspicion of acute leukemia with a blastoid morphology? So based on the morphology, there was a opinion of a differential of probably we are dealing with, maybe we are dealing with a Burkitt's lymphoma or we are dealing with an acute leukemia. We thought of Burkitt's lymphoma, another higher magnification of similar abnormal cells with vacuolation spread throughout, looking very much like Burkitt's cell. So we also thought of Burkitt's lymphoma. But since there was a suspicion of acute leukemia, we did an MPO stain. So initially, this is the neutrophil, which acts as an internal control, and this abnormal cells was negative for an MPO stain, and so was the PAS stain. The tripine biopsy, it again was hypercellular, showing this abnormal cells, which was replacing the normal hematopoietic element. We went ahead with the flow cytometry, and since these cells, if we can recall the morphology, these cells were large cells having a lot of cytoplasmic vacuolation. So that leads to the high side scatter. So CD45 dim large high side scatter populations were gated, and this was the bulk of the population, close to 90%. And we looked for the markers that was expressed. The B lineage markers like the 19, 10, 20 was negative on this abnormal cells, while the myeloid markers in the form of CD33, CD13, and the monocytic markers like CD14, 64, and 36 were positive in this abnormal cells. So now what are we dealing? We thought on morphology it's to be a Burkitt lymphoma. On a flow, we got a CD45 dim population. If it is a lymphoma, we expect a CD45 brighter population. And we got a myeloid specific or myeloid lineage markers in the form of CD33, CD13, 117, and some monocytic markers in the form of 14, 64, and 36. So probably we were dealing with a case of an acute myeloid leukemia showing some sort of monocytic differentiation because 2 or more markers of monocytes were positive. Now, was morphology misleading in this case? We are talking all about morphology. The morphology we did an MPO stain initially, we couldn't find an all rod, so we couldn't assign a diagnosis of MPO. It was only when we did a flow, we found that myeloid lineage specific markers were present. And if I can show the flow plots one again, the MPO staining on this flow was again moderate to bright positive. So that shook us. On the cytochemical stain, we couldn't find these cells to be an MPO positive, but flow was showing very nice moderate to bright positivity of this MPO stain. So we went back to our smear, we reviewed our smear, we again checked that MPO smear, and after counting around about 500 cells, we could see some occasional cells showing this OR rod positivity. So this was initially missed on morphology, but it was there only to be seen, and the OR rods was seen. So if we could have seen those on priority, we could have easily made a diagnosis of acute myeloid leukemia. The point I want to highlight is that morphology always speaks something. It is there for the morphologist to just pick up. We today tend to move to the ancillary test, but if we meticulously spend our slides and review, and there is no hesitation in missing this thing. So this was a learning lesson for all of us, so that MPO was positive, and we need to see large number of cells, good number of cells, maybe 200, 300, 400 cells, to pick up this sort of abnormality, which is there only to be seen and guide us for the final diagnosis. So the final impression was given as acute myelocytic leukemia. Just for the completion of the case, we did FISH and we got amplification of the c-MYC as well as chromosome 8. And there was an KMT2 translocation using a break apart probe. For break apart probe, the fusion pattern is a normal, and if the signals are broken apart, we can be sure that we are dealing with a translocation. In this case, there was also a translocation. So learning never stops at any age. So this is one case which I just encountered a few months back. I thought this is worth sharing. This was a case of a known case of some lymphoma. We could see some abnormal cells, some abnormal lymphoid cells, and some platelet-like structure surrounding this cell. On higher magnification, again, we could see that these platelets are sticking to the surface of this abnormal lymphoid cell. This lymphoid cell was obviously abnormal. I have never seen this cell. I didn't had any clue. So the thing that we did is we Googled it, and we could see some pictures coming on the Google in one of the publication is the lymphoma cells, which shows satellitism of this platelet. And this picture was quite similar to what we got. And we did a review of literature, and we saw that platelet satellitism can be a presenting feature of finding in a patient of a mantle cell lymphoma. We took a detailed history, and we knew that this case was referred from TMC Kolkata, and we knew that we got to know that this patient was a known case of mantle cell lymphoma. So peripheral blood smear can be a good teacher, teaching you provided you spend time with your slides. So the take-home message for my presentation is peripheral blood smear is a first simple tool, but yet exceedingly important for the final diagnosis. And it can tell something that no automated hemolytical analyzer can give. Even it can correct some of the automated findings. It can diagnose the type and the cause of anemia. It is likely to pick up the leukemias and lymphomas. It will guide us to the cause of thrombocytopenia, and we can also have an idea about the parasites. And slides and the morphology will also help us to guide whether to do or not to do bone marrow examination and other ancillary tests. And before I end, I like to say that this is the single drop of blood is all that we need to solve any puzzle, any hematological problem. And each drop of blood speaks a story. It is only for us to see, hear, and communicate it to our clinical counterpart for the best and the timely patient care. So I leave the audience with this pictures, which will make us all proud being an Indian, some proud moments of our country. And today being 5th October, being the International World Teachers Day, I use this opportunity to wish my juniors, seniors, my students, to all those who have taught me and teach me every day a World's Teachers Day. And I leave this audience with this thoughtful process in this drawing text of this medical fraternity in Kolkata and Pan India, written by John Lennon and Louis McMaster, to ponder in your leisure time. And the part of the city that I live and the time, there is a festive scene, so I will not miss this opportunity to wish you all a happy Durga Puja and Navratri. Thank you all for your very patient hearing. Happy to answer any question. Over to you, sir.
Thank you, Dr. Abhishek Sharma, for that wonderful lecture, for a 360-degree overview of the peripheral smear examination, starting from RBC, WBC, platelets, all the abnormal cells you discussed in just 45 minutes at a glance. Thank you. What a wonderful lecture it was.
Thank you,
And
sir.
you're very, very happy Durga Puja and Navratri, as well as you are our teacher today. Thank you. So I now request all our discussants to please put the raising sign so that we can start our question answer session. So first we have Dr. Amrita Saraf ma'am. Ma'am, your question, please. Sir, if you can please unshare your screen.
Yeah, the voice is not coming. Can somebody be a bit louder?
Very good presentation, Dr. Sharma. And I fully agree whatever you have highlighted, because the first step is starts from the history examination and then morphology. Before going for any hi-fi test like flow or molecular, I think we can make mistakes if we don't see peripheral blood carefully or we don't take a history and examination. So I have a remark to make, and then I have a question also. I think first I'll ask my question. Like you highlighted that there may be pseudothrombocytopenia in the peripheral blood smear, and we often ask for like citrated sample to make sure that we are not making a mistake and we are not underestimating platelets. But still, in citrated samples, we get these clumps. So, what next would you like to suggest if we are getting these clumps and big aggregates of platelets, even in EDTA sample and citrated sample?
So this is a very common problem, ma'am, that we do get uh, pseudothrombocytopenia on an EDTA blood. So what I do is I just correlate with my histogram plots. So if we look at the histogram plots with the platelet histogram, so there is a baseline touching. If the baseline is touching smoothly, then I'm sure that the count that is given in the automated cell counter is a correct count. Firstly, secondly, if we if we are getting a EDTA induced clumping or satellitism that can lead to pseudothrombocytopenia, we also in our institution ask for a citrated blood. And in citrated blood, I have not seen too frequent that the clumps are there. That usually solves the problem in most of the cases. But if still there is a clump, even on the citrated blood, I think repeat sampling and just to report it, if we are getting a single clump or maybe one or two clump, that indicates that the platelet count is near normal.
Yeah, here I would also like to add, because I have worked with Professor Sood. So what he used to say, like, if you are not sure about the analyzer's count and you're not sure, you're not happy even with the citrated, which definitely what you are saying is correct, doesn't happen very frequently, but once in a while, better to get a finger prick smear and then check, because now there is no anticoagulant and it's not a big thing, just a finger prick smear. Look at it and you can correctly decide whether how much is it based on that rough calculation. In high power field, how many platelets are there, which includes whether they are small, whether they are normal size, or they are macroplatelets. So that is like one thing I learned from him. So I just wanted to share that.
Yeah,
And
definitely. Yeah, ma'am. Totally
yeah,
agree. But the problem that we sometimes face in our institution, we don't get patients coming too often for this finger prick sample. But definitely, that is
for
one thing that
admitted
we can
cases,
do.
it's easier. But yeah, for the patients coming from outside or like OPD patient, it may not be that easy. So, but still, it's like a very old, but I think a good way to be sure, because sometimes even the histogram baseline is not reliable. So, and what we know that they look like maybe more than 1 lakh, and it is giving a count of, like, say, 25,000 and very, very low. And we are very sure that they are more than this. Patient is waiting for a procedure to happen, and the surgeon wants to know what to do. So that is another thing. And especially, like, in this season when we are seeing a lot of dengue, chikungunya. So sometimes these lymphocytes, which you also highlighted, which show atypical morphology, so that can easily confuse anyone. Like, I would say that once we see these atypical looking lymphocyte, it should not be interpreted as malignant. or reactive. By it, maybe what I'm saying is more for clinicians. Like once we say atypical, it means something which is not typical, but it could be transformed. It could be sometimes representing a lymphoma cells. So that is also important that it needs to be correlated with microbiology and history of fever is usually there, but correlating the morphology with clinical and examination finding is very, very important before we go for a bone marrow and flow cytometry and other tests. And one more finding I would like to share that like stomatocytes were there in a patient's peripheral smear, and it helped in making a diagnosis of ketoacidolemia, which is which was proved by genetic testing. So a lot of things peripheral smear teaches us. So thank you so
Totally
much.
agree. Totally.
Yeah, thank you so much.
Thank you, ma'am.
Thank
Dr.
you.
Ankur, your question, please.
Yes, sir. Dr. Abhishek, as usual, I am fond of your lectures. We know that I listened to you in last Metacon also. So, as such, no question because you have cleared everything. The only comment which I can say is sometimes the clinical history or clinical examination also we don't get the findings. Likewise, I'm just narrating just short summary of two cases in which one of the patients, a child with a recurrent pyrexia of unknown origin, was getting admitted again and again. So, and incidentally, we found that platelets were very small and the MPV was very low. So, we advised for viscous outreach, which came out to be positive for the mutation.
Right.
So, that PBS finding is actually very, very important. But in that case, the child was roaming here and there for last few months. Similarly, another case, another recurrent pyrexia of unknown origin was getting admitted, very obese, but unable to find the etiology, was transferred to us, a BB being the referral hospital. So we found, again, we had a suspicion of a church class, and it came out to be positive. So I feel if PBS is being looked after very well, we can do some miracles. And as you're right, PBS is a window for the bone marrow. Thank you, and very nice lecture. Heartiest congratulations. Thank you.
Thank you, Dr.
Thank
Ankur
you.
Ahuja. Dr. Meenu Angi, your question, please.
Hello, thank you. Thank you. Very nice presentation, sir. As Dr. Ankur said, I also have no question, only a comment. Can you hear me?
Yes, sir. Yes, ma'am.
So in APML especially, I feel if count is very low, it should be firstly examined under low par. This is especially for the residents. So if they see in low par, they can identify those cells. Even at the count of 200, 500 WBC count, we can identify those cells. And as a cytogeneticist, I feel that diagnosis of APML should come from peripheral blood examination. From that, if history is there, we are also very comfortable in reporting.
True. Thank you. Thank you, Dr. Meenu Angi. So, Dr. Abhishek, we have some questions from the audience.
Yes, sir.
So the first question is from Dr. Ong. When to suspect MAHA by cystocytes in peripheral blood film? And how to differentiate between cystocytes in other cases of intravascular hemolysis from microangiopathic hemolytic anemia?
So as far as microangiopathic hemolytic anemia, again, as already many of the discussion has emphasized, the first and the foremost thing is the clinical presentation. So we'll have a clinical presentation that will guide us whether we are dealing with a true MAHA, TTP, HUS, or whatever. Second thing is to look for an cystiocytes. And when we look for a cystiocytes, the paper that I was referring to, there are different morphological entities of fragmented RBCs that are classified as cystiocytes, like triangular cells, helmet cells, even the microspherocytes. Microspherocytes in appropriate clinical background has to be called or has to be documented or qualified as an cystiocytes. Second comes the percentage of the cystiocytes. How much cystiocytes are present? So the normal cutoff that is used is 1% if we are sure that these are true cystiocytes. But the paper that I was referring, if we are looking for a patient of a bone marrow transplant suspected to have some sort of hemolysis, now this percentage is bit increased. I don't remember it correctly, but I think the percentage is 2%. So that is very well nicely documented in that review article. You can go through this. But as far as MAHA is concerned, clinical history, identification of true cystiocytes, and the correct percentage will help you to sign out your report.
Thank you. Dr. Chamindi, you have a question? Dr. Chamindi Jayasundara? Okay. So another question from Dr. Raj Warrior. Can you comment about erythrophagocytosis as a hallmark for autoimmune hemolytic anemia?
Erythrophagocytosis as a hallmark of autoimmune hemolytic anemia. Yes, I will say that this is one of the findings that can guide you, but it is not itself diagnostic of autoimmune hemolytic anemia, because erythrophagocytosis, or if in case of hemophagocytosis, these are non-specific findings. Depending, there are conditions like HLH, or there are certain infections like typhoid infections where we can get this type of erythrophagocytosis. So yes, they can help in as a diagnostic clue, but I'll not classify it as an hallmark.
Thank you, sir. But I would just like to add a few notes on this. I think erythrophagocytosis is a very common entity for and hallmark for PCH, paroxysmal cold hemoglobinuria.
Yes.
So I think not for autoimmune hemolytic anemia, but maybe for PCH, it is a hallmark feature of getting erythrophagocytosis, paroxysmal cold hemoglobinuria. Another question from Dr. Raj Warrior. Pyruvate kinase deficiency may show irregular cell membrane. Do you get this kind of picture in every case of pyruvate kinase deficiency?
Pyruvate kinase deficiency. I heard it right?
Yes.
Pyruvate kinase deficiency. The case I had one case, but due to lack of time, I couldn't discuss this. The morphological clues as far as pyruvate kinase deficiency, we don't get too much. There can be some sort of membrane disorders or membranopathy irregularity, but that any typopathy. You cannot, which you are referring is of pyruvate kinase. So for pyruvate kinase, and the important thing to remember of pyruvate kinase enzyme is it exists in 2 or more isoform. Even if you go for a genetic test, you will have some problems because there are 2 or 3 clinical isoforms of pyruvate kinase, which leads to diagnostic challenges. So as far as morphology is concerned, you can document that there is hemolysis. And if you are not able to pick up common causes, molecular is the way to go and establish your diagnosis as far as pyruvate kinase deficiencies. If anybody other have any suggestions or experience on pyruvate kinase on morphology, can please say.
So Dr. Raj Warrior has commented about porcupine cells, which are the hallmark for pyruvate kinase deficiency.
Which cell, pardon?
Porcupine cells.
Porcupine cells.
Yeah. So which
I
shows
don't have any experience on
irregular
this.
projections on the cell membrane, and they are known as porcupine cells. Anyways, any other question from Dr. Raj Warrior is, any comment of picking up HLH on the peripheral smear examination?
HLH on peripheral blood smear examination, again,
Yes.
I don't think there are definite thing that we can comment, but yes, increase in monocytes and a bit of shift to left can have an indication that we might be dealing with HLH. But for HLH, again, bone marrow is required, and even for bone marrow, not only hemophagocytosis, if we can document that the histiocytes have engulfed the neutrophils in good quantity of number, that is one of the more important morphological diagnostic clue. But even in absence of this classical hemophagocytosis, there are other diagnostic criteria that needs to be fulfilled.
Thank you. Another question from Dr. Myat Maleshwe. She wants to know about how long should we put air dry for the peripheral blood film before staining?
how long should we put the blood smear to air
Air
dry?
drying. Air drying, yeah.
So
Before
there
going
are
for staining.
there are no specific time bound. You have to be sure in what place and what conditions you are putting up your smears. You have to just see the slides morphologically that it has perfectly dried, and then you can put your staining. There is no cutoff as of 1 minute or 2 minutes or something like that. It all depends on what climatic condition you are preparing your smears.
Thank you. And the doubt she has is, for fixation with 20% methanol, can she prepare 20 ml of absolute methanol to 80 ml of distilled water?
Can you repeat the question, please?
For fixation with 20% methanol, can
Yeah.
she prepare 20% methanol as 20 ml of absolute methanol added to 80 ml of distilled water?
So if this question is regarding fixation of peripheral blood smear, first of all, we use Romanovsky stain or Leishman stain. When we are using Leishman stain as a basic stain, we don't need to separately fix our smear if you are talking of a peripheral blood smear, right? So as far as peripheral blood smears are concerned, we don't need extra separate fixation.
Dr. Abhishek, we can't hear you. Your voice is breaking. Dr. Abhishek?
Desired concentration, and you can fix it for a maximum.
Dr. Abhishek, we can't hear you. You're muted.
Hello,
Okay,
is
we lost
it
you.
audible?
Now you're audible.
Could you hear me the answer of the previous question?
No, we could not hear you. So the
Okay.
question was basically about fixation with 20% methanol. Can it be done by adding 20 ml of absolute methanol to 80 ml of distilled water?
Yeah, it can be done. But as far as the peripheral blood smear is concerned, we don't need to separately fix the smears because the routine stain that we are using itself has the fixative. So for routine staining, we don't separately fix the smears and go for staining. But in any case, for any special stain, you need separate type of fixation. You can do it.
Okay, thank you. Another question is, for fixation with 20% methanol, how long should be kept? The blood film should be kept in the fixative.
1 minute. 1 minute is the ideal time that should take care of the fixation of the smear.
Perfect. And another question is, which stain is the best to detect the polychromatic cells?
Polychromatic stain. See, the peripheral blood smear, the stain that we routinely use, we have not done a comparative study of two different stains, and so but Leishman Jimsa stain is quite good enough to pick up the polychromatic stain if you have prepared it nicely and stained it nicely. It shouldn't be a problem.
Thank you. Another question from Dr. Ratika, and she wants to know that how do you differentiate species of plasmodium on peripheral smear?
So this is
any easy pointers?
Yeah, so different species of, this is a separately total lecture. I had few slides, but in the interest of time, I think I'll skip this. We do have soft pointers in differentiating between the different species of plasmodium, and there are also pointers between vivax and falciparum, but it's a busy thing, so I think I'll skip in the interest of time.
Hello. Dr. Amit,
Yes.
can I ask something?
Yes, please go ahead, ma'am.
Yeah. I'm Dr. Savitri. Some technical issues, so I cannot be seen here. Very nice lecture by Dr. Abhishek. And it was good to know that platelet satellitism in a case of lymphoma, and that is like he could assign that it could be because of mental cell. We have seen cases of platelet satellitism, but I was not aware of that it could be in a case of lymphoma. Another thing I would like to add is that we might get rarely, you have to really look into it. cases where we can get erythrophagocytosis. We had a case, child of 15 or 3 months, 15 days old, post-op, and every time platelets were falling, and clinician were giving platelets, again they were falling. And then I thought, let me check peripheral blood smear. What's the issue? Why child is not recovering? And then we saw that there was erythrophagocytosis and also one monocyte having platelets also phagocytose, and that was seen in peripheral blood smear. So if we think, I think we might get, that's one thing. Another case, we saw critically ill child, known case of AML on treatment, and we could see in neutrophil bluish granules. That's what is known as blue green crystals, that is called death crystals. And that's very rare finding, but we could see that, and we thought, let our clinician know that that's a bad omen, that child might not survive. We can't put it in this thing exactly like they are death crystals, but indirectly we mentioned some crystals, blue green crystals are seen, and like correlate clinically. So that was something very nice what we learned today. And another thing I would like to add, because we are in a pediatric institute, whenever we are seeing any finding of peripheral blood smear, always try to correlate with the analyzer histogram, because we have picked up quite a few cases of microplatelets, and for the patient was of course presenting with eczema, skin rash, repeated infections, and we got finally molecular done, and it turned out to be Viscott-Ellis syndrome. So well-fitted platelet graph, we can give value as such, whatever the platelet count. But if it's MPV also to be seen in clinical correlation and morphology, then we can arrive at a rare diagnosis. At least we can give clue to clinician to pinpoint and then do molecular and confirm it. That's it. Thanks very much.
Thank you, ma'am. Thanks a lot for that insight. Dr. Chamindi, you had another question?
Yes, sir. Thank you. Am I audible?
Yes, you're audible. Please go ahead.
Okay. Thank you for the beautiful story of morphology. And the question I would like to ask, sir, your experience regarding the peripheral smear and the bone marrow morphology in APML and the concordance of when you suspect APML, then you would tend to do the FISH. So the concordance or the discordance of getting the FISH positivity when you suspect morphologically APML. Sometimes with morphology, cytochemistry, as well as flow cytometry, when we strongly suspect APML, sometimes the FISH or then the molecular genetics might come negative as well, especially with AML with NPM1 mutation. How often would you see that?
So
Yes,
if I
Dr.
heard it correctly, this is regarding.
Yeah, the first question is regarding the discordance between the morphology of APML and the FISH. And the second question is basically regarding the discordance between the cytogenetic abnormality and the NPM1 mutation.
Right. So I'll take the first question, that is regarding APML and discordance of FISH. So as far as APML, so there are classical APML and hypogranular APML. Morphology is never misleading. If you see an abnormal promyelocyte, if you can very well see the phagot cells or the or rods, you are very sure that this is an APML. But since it is an molecular or genetically defined entity, you need to document PML via translocation. Now, the first and the foremost technique that should be used for PML RARA is an RT-PCR. It's a molecular technique because it will not only help us to detect PML RARA, but it will also help us to give the transcript type. Once the transcript or the RT-PCR is negative, then we can go for a FISH, because there have been some cases which we have seen where the molecular or the RT-PCR is negative, but PML RARA translocation can be picked up on FISH. Similarly, on the contrary, in our part of the city, especially in private labs, here the practice is to go for fish for PML RARA upfront because the TAT is on the lower side. And they go for molecular testing after if the fish is negative. So similarly, if the fish is negative and if the morphology is highly suggestive, you will have to go for a molecular genetic study, that is RT-PCR, which is the modality of choice, and RT-PCR will pick up most of the cases. Yes, I have seen some cases where there is discordance in the molecular genetic as well as fish, but those percentages are very less. It will be closely around about less than 10% in my experience. And the second question was regarding
NPM1 mutation
and morphology.
and the morphology and the discordance with the genetic profile.
Right.
Yes,
So
sometimes
the morphological clue for NPN1 mutation, when we are looking at a blast, we look for the nuclear cupping. And if this cupping is there, then we think that this is an NPM1 mutation. I have not, my personal experience about NPN1 and nuclear cupping correlation, but usually this nuclear cupping, if it is a classical nuclear cupping, it correlates well with NPM1 mutation. But I don't have the exact numbers how it correlates or what is the discordance.
Okay, thank you. Another question, Dr. Chamindi? Fine.
That's also because sometimes morphologically and flow cytometrically, when we have suspected APML, the RT-PCR and the fish had come negative, and the NPM1 has come positive. So sometimes there's a bit of morphological overlap as well. That's why I thought I would ask this experience as well. Thank you very much.
Thank you, Dr. Chamindi. Another question from Dr. S.K. Sharma. He wants to know what happens to RDW in patients of thalassemia with concomitant iron deficiency. Is there any clue on peripheral smear examination also that the patient has both thalassemia plus iron deficiency anemia?
Now it all depends. Now you're talking of two different disease entity, IDA plus thalassemia. You need to know which component is more. If the iron deficiency is the predominant component, then you might get a higher RDW and you will get a microcytic hypochromic picture. If the thalassemic component is the predominant one, the RDW might not be affected. It all depends on the balance of which component is overtaking the other.
True. Thank you. Another question from Dr. Rahul Bharti. Why MPO is strong positive in APML?
Why MPO is a strong positive? So APML is a acute promyelocytic leukemia, and the promyelocytes are the cells where we get the primary granules. And here the promyelocytes are not normal. These are abnormal promyelocytes. Even for the hypogranular variant, as I said, hypogranular variants, we don't tend to see the granules. But if you do an MPO stain, it will still be strongly positive. It is the granules are there to be seen, but it is less than the resolution of a light microscope. So since these are primary granules and these primary granules are rich in MPO, so they will tend to be MPO positive, both in classical as well as the hypogranular variant, I presume. That satisfies.
Thank you. Another question from Dr. Ali Dinky. Can you diagnose acute leukemia only from peripheral blood smears without doing a bone marrow examination?
Yes, we can, but it depends on which clinical stage the patient is presenting. So as far as the cutoff is concerned for morphology, it still remains to be 20% apart from the other molecular defining entities like PML, RARA and other things that we can even diagnose. But yes, we do see cases of peripheral blood smear where there are sufficient number of blasts. We avoid bone marrow and we do all the tests, including the flow cytometry and molecular genetic test, even the cytogenetics on a peripheral blood smear, if we get the abnormal cells.
Thank you. Another question is that in neonates, the hematopoietic site is still the liver. So is peripheral blood smear superior than the bone marrow examination when we suspect any congenital leukemia?
Is the peripheral blood smear better than bone marrow when we are suspecting congenital leukemia?
Yes, because
No,
for
I
the
don't.
hematopoietic site is liver.
Yeah, I don't think peripheral blood smear is superior than the bone marrow for congenital leukemia. If you look at the pathogenesis of congenital leukemia, the mutation or the genetic alteration starts itself in the in utero. So till the time the child is born, you have mutations. So there is a tendency that the abnormal cells will be present in quite good number and in good percentage of cases on peripheral blood smear. So you will get that abnormal cells in a peripheral blood smear, but it's not about the superiority. And the most common translocation that is seen is KMT2A translocation. Again, as I said, if you get sufficient number of abnormal cells on a peripheral blood, you can go ahead with your translocations and mutation study on a peripheral blood. But still, bone marrow is considered a little bit better or on the higher age as far as genetic test is concerned, because the mitotic activity or the cell growth tendency is better in a bone marrow cells than peripheral blood. But it all depends on the percentage of abnormal cells that we see on a particular specimen on a given case.
Thank you. Another question from Dr. Jyoti Sauni. What is the relevance of nucleated RBCs in a case of acute leukemia, especially AML? And what should we think in such cases?
Could you kindly repeat the question?
So what is the relevance of getting nucleated RBCs in a case of acute leukemia, especially in cases of AML? And what should we think when you get NRBCs in case of acute leukemia, mainly AML, in the peripheral smear?
So is the question of getting a mutation in NRBCs?
What is the relevance of nucleated RBCs in a case of acute leukemia, especially AML?
Okay, got it. So nucleated RBCs, right?
Yes,
Right.
yes, correct.
So she is talking about peripheral blood smear.
So peripheral blood smear with acute myeloid leukemia, and you get plenty of NRBCs on the peripheral smear with AML. What is the relevance of it, and what should we think of in such cases?
See, if you are getting a plenty of NRBCs and depending on the other clinical inputs, and you are getting a classical myeloblast, you need to exclude your erythroid leukemia. So again, you need to have your bone marrow, and you have to see the precursor of your erythroid cells, and they are defined cutoff points where you need to classify according to the older nomenclature as M6, 6A, or 6B. So if you are getting quite good number of NRBCs, and if the morphology of the blast fits, you should think and exclude M6.
Exactly. Another question from Dr. Durga. How would you report platelet count if immature platelet fraction is very high?
Immature platelet fraction.
Yes, IPF.
Okay. So if the immature platelet, we generally don't give this parameter in the reports. We just rely on the morphology or the morphological count of the platelets. But if there is an immature platelet fraction is more, if the clinicians want that information, we put it as a rider that indicates that there are more proliferation or more reticulated or younger platelets coming up. But we don't report this parameter as of routinely. And I don't think this immature platelet fraction will have a bearing on the total platelet count. It will just give an indication on the productivity of the platelet in near future.
Thank you. So if you get a case of thrombocytopenia, and if you see lots and lots of giant platelets or macroplatelets, will you change the value of automated analyzer and increase the platelet count on your report?
Again, can you just repeat this, sir?
So in a case of thrombocytopenia, if you look at the platelets and your platelets are giant platelets or macroplatelets,
Right.
will you change the value of your automated analyzer and increase the platelet count, seeing the giant platelets or macroplatelets?
No, I don't think giant platelets will have a bearing on the total number of platelets count. We just need to document it that they are giant platelets. It is only when the platelets tends to aggregate or have a clumping or some sort of satellitism we tend to change the platelet count. But just mere presence of giant platelets, we don't tend to increase the platelet count. But we need to document it that it is mega thrombocytopenia. It is thrombocytopenia with presence of giant platelets. And we need to look for other causes of those.
Thank you. The question from Dr. Pai Pio. How would you differentiate a reactive eosinophilia from chronic eosinophilic leukemia by morphology or by spatial stains on peripheral blood film?
See, again, there is nothing concrete that we can pick up on morphology, but yes, there are diagnostic clues. As I have shown in one of my slides, if the eosinophils are increased, it can be reactive, it can be clonal. But if you look at the granules of the eosinophils, in case of usually when it is a clonal eosinophilia, the granules tends to be irregularly distributed or concentrated to the one particular zone of the cytoplasm. That is one point. If you get hypersegmentation of the eosinophils, that is another point that you are dealing with a dysplastic or maybe a clonal eosinophilia. But as far as clonality is concerned, we again have to rely on other diagnostics. But these are definitely diagnostic clue, soft pointers, which will help us to think that we are dealing with clonal eosinophilic syndrome.
Thank you. Another question from Dr. Raj Warrior. Any comments about inclusions in tick infections?
Inclusions in
Tick
infections. I don't have any experience on this, sir.
No problem. Dr. Ritesh, you have a question?
Hello.
Dr.
Hi. Just about my comments on the platelet count in giant platelets found on smear. The automated cell counters often use the impedometric principle while counting platelets. So when you get a giant platelets, more than 30 femtoliter, they are counted as RBCs. So the impedometric platelet count is less than the actual count. So in case when we find giant platelets on smear, we tend to advise optical platelet count, or even for some challenging cases, there are the flow cytometric platelet counts also available.
Yeah, agreed, sir. So as far as giant platelets, we don't rely on the automated cell counter platelet, but we rely on the slide count of the platelets, and we give that count and we document whether that is giant platelets.
Exactly, we can estimate the count when we find giant platelets on smear. That's my comment.
Right.
Thank you. So I've finished all the questions from the audience. Any discussion want to ask any other question? Well, so I think there are no more raising signs and no more questions from the audience. Well, Dr. Abhishek Sharma, fantastic and lovely lecture and a wonderful discussion. That was a 360-degree view of all peripheral smear examination, starting from RBC, WBC, platelets, giant platelets, abnormal cells. You touched about everything in this 45 minutes, what was given to you. That was beautiful. And what a wonderful discussion we had. Thank you, and meet you all tomorrow at 11:30 a.m. And I now hand over to Zydus, Dr. Shrivas Bharat, for the final vote of thanks.
Thank you,
sir. Thank you, Dr. Rohit, sir. Thank you, Dr. Abhishek, sir, for excellent session. We learned a lot today. I would like to thank MHG for letting us be the part of today's meeting. I would also like to thank Dr. MBA Agrawal, sir, for giving this opportunity to us. And lastly, we'd like to thank Dr. Amit, sir, for letting us be a part of today's discussion. Thank you, everyone. Good night.
Thank you. Goodbye to you, and meet you all tomorrow at sharp 11:30 a.m. with another beautiful webinar. Goodbye for now.